Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Novo Nordisk AS.
This program is presented by Medscape Education Global.
Hi, everyone. My name is Dr. Sue Peterson. I am an endocrinologist at Siendo Endocrinology Clinic in Calgary, Canada, and I am a clinical lecturer at the University of Calgary and a diplomat of the American Board of Obesity Medicine. The title of today's presentation is Reshaping Obesity and Diabetes Care with Innovative Multiagonism Concepts. So in the next 35 minutes or so, let's cover the following objectives together. Let's talk about obesity prevalence and obesity-associated health conditions. We'll then talk about what current 2025 obesity pharmacotherapy guidelines recommend for treatment of obesity and related health conditions. And then finally, we'll review the mode of action and data for emerging hormone-based combination therapies currently in clinical development. Obesity is a growing global health epidemic. Globally, the number of adults with obesity has doubled since 1990, and the number of adolescents with obesity has quadrupled. Around the world, about 1 in 8 people are living with obesity, with about 2.5 billion adults with overweight and 890 million with obesity. In 2024, 390 million children and adolescents were living with elevated weight, including 160 million who were living with obesity. Now, if we touch on type 2 diabetes as a health condition that often goes hand in hand with obesity, the number of people living with diabetes rose from 200 million in 1990 to 830 million in 2022, with the fastest increases in low and middle income countries. If we consider the overall burden of diabetes globally, more than 90% of people with diabetes have type 2 diabetes, and adiposopathy, or excess body fat causing disease, is behind type 2 diabetes in almost all cases. And in most countries, only about half or just less than half of patients are at glycemic target. Obesity is associated with over 200 health conditions, which can involve essentially every organ system and medical specialty. So, as obesity is defined as the presence of excess adiposity causing disease, we have to think about this long list and think about how adiposity is impacting our patient and what health conditions may be conversely contributing to that excess adiposity. So, to make that a little easier to handle, we can think about health conditions associated with obesity being metabolic, such as type 2 diabetes, hypertension, dyslipidemia, cardiovascular disease, and so forth, mechanical, such as sleep apnea or osteoarthritis, or mental health, depression, anxiety, and so forth. Consequently, with this long list of health issues associated with obesity, obesity is also associated with reduced life expectancy. Okay, now let's talk about what current 2025 obesity pharmacotherapy guidelines recommend for the treatment of obesity and related health conditions. So first, let's ask the question, well, why should we use weight management medication in clinical practice in the first place? Well, we know that health behavior change alone usually only results in about 3 to 5% weight loss and is most often insufficient for achieving sustained weight loss and improvement in obesity-related health complications. So if we look at these clinical trials where people with lifestyle in these trials may have had more success than what is seen in the real world initially, every study shows that there's a progressive weight gain after that closely monitored clinical trial of lifestyle-based treatment is over. So, pharmacotherapy is therefore an important treatment modality in obesity management and should be utilized to decrease weight, optimize health, and support health behavior changes. One of our key messages in our Obesity Canada Pharmacotherapy Clinical Practice Guidelines, which were published in August 2025 and on which I'm the lead author, is that we want to treat obesity, treat early, and treat long term. We don't want to wait until our patient has developed health issues related to obesity before we start thinking about treating their obesity. Of course, if they present to us for the first time with established obesity related health issues, of course we want to offer weight management treatment to those individuals. But the point here is that the earlier we treat obesity, the better chance we have of helping people to be healthier and stay healthier. So here's an example using the progression of dysglycemia to highlight this really important point. In the diabetes world, historically, we've been used to treating patients once they have already developed diabetes, diabetes related complications, and then perhaps address weight at that time. But now consider, what if we had treated that patient earlier? For example, when they were first diagnosed with diabetes, but before they developed complications. Maybe we could prevent their development of complications and delay or prevent the progression of their diabetes. Now consider, what if we treated them even earlier at the stage of prediabetes before they even get type 2 diabetes? We might be able to prevent progression to type 2 diabetes and even regression to normal glycemia. So on and so on. If we back up earlier to the point where the patient has obesity but doesn't yet have health complications, we can really have an impact to give that patient excellent health over the longer term and perhaps prevent obesity related health conditions from developing in the first place. So, how do we choose which medication is best in the treatment of obesity? So, in our recently published Canadian guideline, we have assimilated the data into a very easy to use decision tool and table that helps the clinician select the best medication for their patient. So, here's our table where we focused on improving health with a list of the obesity related health complications for which obesity pharmacotherapy has shown benefit down the side. And across the top, we list the obesity pharmacotherapies. We've also included the average placebo subtracted weight loss across the bottom. Now, here are some of our key recommendations from our pharmacotherapy guidelines for obesity related health conditions and how obesity medications should be used to facilitate weight management in addition to improving these obesity related health complications. There are 7 obesity related health conditions upon which there was evidence to generate recommendations for treatment with obesity pharmacotherapy. So let's go through those. The first is atherosclerotic cardiovascular disease. Obesity is strongly associated with cardiovascular risk factors and is a major driver of atherosclerotic disease, which remains a leading cause of morbidity and mortality worldwide. So, we recommend that pharmacotherapy should be used in conjunction with health behavior change to reduce the occurrence of cardiovascular events in people with established ASCVD and a BMI of 27 or greater, in addition to standard of care. And for here, this recommendation, there's data for semaglutide 2.4 milligrams weekly. Now you'll see there's a star beside the BMI, and then it says at the bottom, see recommendation 1. So, in our first recommendation, which is very central to our guidelines, we recommend looking not just at BMI, but also waist to hip ratio, and waist to height ratio for assessment of excess adiposity, and to use these to determine whether a patient may qualify for weight management medication. So, for example, if a patient has a BMI of 26 but has a waist to height ratio greater than zero point 0.5, they have excess adiposity by that waist to height definition and thus should be considered a candidate for obesity pharmacotherapy. Okay, let's now move on to heart failure with preserved ejection fraction, or HFpEF. This is very common. Obesity is common in people with HFpEF. Weight loss improves HFpEF in people with obesity. So we recommend pharmacotherapy in conjunction with health behavior change, in addition to standard of care in people with HFpEF and BMI 30 or greater for weight loss and improvement in HFpEF parameters. And the medications are listed on the slide. And again, we have that caveat for the BMI where we want to consider other anthropometric criteria as well in making the decision of who may be appropriate for pharmacotherapy. The next one is prediabetes, which of course is very common in people with obesity, and the risk to progression for type 2 diabetes is high. So, we recommend obesity pharmacotherapy with health behavior change for people living with prediabetes to reduce risk of progression to type 2 diabetes or achieve normal glycemia with the medications listed on the slide, which have demonstrated benefit to these parameters. The next one is type 2 diabetes. Here we recommend obesity pharmacotherapy with health behavior change in people with type 2 diabetes for weight loss and improvement in glycemic control, with all 5 of the main medications for obesity available in Canada listed here with their respective levels of evidence. Next one is metabolic associated steatohepatitis, or MASH. MASH, or MAFLD, affects about 25% of adults globally, and weight loss is integral to the management of MASH and MAFLD in people with obesity. So, we recommend that pharmacotherapy may be offered with health behavior change in treating people with MASH for weight loss and resolution of MASH without worsening of fibrosis, and improvement of at least one fibrosis stage without worsening of MASH, with the respective medications listed for each of those recommendations where there was evidence for benefit. Next one is sleep apnea. Sleep apnea also is common, with excess weight being a leading risk factor. Weight reduction can reduce sleep apnea severity and improve related health outcomes. So, we recommend pharmacotherapy in conjunction with health behavior change for weight loss and improvement in apnea hypopnea index in people who are living with moderate to severe OSA and BMI of 30 or greater, with that caveat on evaluating BMI. And that is in people who are unwilling or unable to use positive airway pressure therapy and those who are using positive airway pressure therapy with the medications listed demonstrating benefit. And the last one is osteoarthritis. Knee osteoarthritis can be caused not only by increased weight stress on the joints, but also by the chronic inflammatory state of obesity. Managing weight effectively can reduce knee pain, enhance physical function, and may slow osteoarthritis progression. We recommend that pharmacotherapy for obesity management should be offered with health behavior change for people living with knee osteoarthritis, BMI of 30 or greater, for weight loss and reduction in knee pain with the medication semaglutide 2.4 milligrams weekly, demonstrating benefit here. Okay, now that we've covered off the obesity guidelines, let's now talk about the mode of action and data for emerging hormone-based combination therapies currently in clinical development. And this is such an exciting area. I'm delighted to speak with you about this today. Now, as we move on to talk about emerging medication, and while the focus is not solely on weight reduction, we do know that we tend to see more improvements in health conditions with a greater amount of weight loss. Metabolic health improvements start with even just a small amount of weight loss. We need 5 to 10% weight loss to see improvement in, for example, MASLD, musculoskeletal issues. We need to see at least 10% weight loss to see potential reduction in cardiovascular disease, 15% weight reduction for HFpEF benefits or cardiovascular mortality benefits. So it's exciting to see with the current and now emerging pharmacotherapies, we're closing the gap between weight loss with health behavior change and at the other end of the spectrum, weight loss with metabolic and bariatric surgery with pharmacotherapies, with new and emerging pharmacotherapies providing greater weight loss. However, it is essential to appreciate that the benefits of these medications to health are not all simply related to weight loss, and there are other mechanisms at play which may be independent or partially independent of weight loss. For example, reduction in inflammation, glycemic benefits, and so forth. In the natural biology of weight regulation, we know that there are many hormones feeding into the homeostatic regulation of food intake. This includes the hunger hormone ghrelin, and there are many satiety hormones at play: GLP-1, GIP, amylin, glucagon, CCK, PYY, leptin, and others. Several of these hormones also work on the hedonic regulation of appetite, which also happens in the brain. This is the wanting and liking of food and cravings mediated by dopamine and opioid release. For example, the GLP-1 receptor agonist semaglutide has been shown to be of benefit to reduce cravings. So now let's talk about potential benefits of using nutrient-stimulated hormone-based therapies in combination approaches, including various combinations of GLP-1, amylin, glucagon, and GIP. So first, let's talk about the combo of GLP-1 and amylin. We're very familiar with the effects of GLP-1 already, as a satiety hormone, delays gastric emptying, and has glycemic benefits. Amylin is a hormone co-secreted with insulin from pancreatic beta cells in response to food intake. It works to regulate postprandial glucagon secretion, reduce appetite, and slow gastric emptying. Amylin reduces appetite by targeting homeostatic appetite regulation in the brain and may also target areas involved in hedonic aspects of weight regulation. CagriSema is a combination treatment of cagrilintide, an amylin analog, with semaglutide. The REDEFINE 1 trial was a randomized study of over 3,400 people with overweight or obesity without diabetes, designed to compare the effect on weight of CagriSema 2.4 milligrams weekly versus placebo. Treatment options of semaglutide and cagrilintide monotherapy were included for an interesting comparison. At 68 weeks, weight loss was 20.4% with CagriSema, 14.9% with semaglutide monotherapy, 11.5% with cagrilintide monotherapy versus 3% with placebo. Categorical weight loss was greater for CagriSema versus Sema, Cagri, or placebo. And here I want to draw attention to the weight loss of at least 25% being seen in 35% of people in the CagriSema group, over double the proportion than in other treatment groups. 15% of people in the Sema group, 7% in the Cagri group, and just 1% of those in the placebo group. Health improvements were seen with CagriSema, including impressive improvements in blood pressure, metabolic health parameters, and physical function. Our Redefine 2 trial, on which I was the senior author, we published this in the New England Journal of Medicine. This included just over 1,200 people with BMI of at least 27 with type 2 diabetes, randomized to receive either CagriSema 2.4 milligrams weekly or placebo. So note here that Cagri and Sema were not studied separately in this trial. At 68 weeks, weight loss was 13.7% with CagriSema versus 3.4% with placebo. When we look at categorical weight loss on the right in this slide, we see that CagriSema well outperformed placebo. At least 20% weight loss was seen in 23% of people with CagriSema versus just 0.5% of people with placebo. We found that hemoglobin A1C was reduced by 1.8% with CagriSema versus 0.4% with placebo. Our study was the first phase 3 weight management study to include continuous glucose monitoring in a subset of patients, where we found that the time in range at the end of the study was 88% with CagriSema versus 51% with placebo. Greater improvements in blood pressure, metabolic health parameters, and physical function were seen with CagriSema. CagriSema is also under evaluation currently in a cardiovascular outcome trial. So, as Redefine 1 and 2 were two large phase 3 studies with a cumulative about 4,600 patients, this is an important opportunity to evaluate safety and tolerability of CagriSema as well. The most common side effects were gastrointestinal, specifically nausea, vomiting, diarrhea, and constipation. Numerically, a little more common with CagriSema than in the other treatment groups, and mostly mild to moderate in severity. GI adverse events were most commonly seen during dose escalation and decline thereafter, and adverse events leading to treatment discontinuation were low, and no unexpected safety signals were observed. So, what happens if we approach dual targets of GLP-1 and glucagon? Well, with GLP-1 agonism, we get robust glycemic control, satiety, and reduction in cravings. With glucagon agonism, we have an effect to induce satiety, potentially to increase energy expenditure, catabolic actions of glucagon in the liver, increasing hepatic glucose production, and also stimulation of lipid oxidation. So, with a balanced dual GLP-1 glucagon agonist approach, we might expect to see weight loss and potentially a benefit to glycemia. The benefits of the GLP-1 glucagon agonists currently in development are quite heterogeneous, with some being quite impressive based on early data for weight loss, some not so much, some beneficial for glycemic control and some not, and some very impressive for MASH. This heterogeneity likely reflects variability in potency as well as the balance of GLP to glucagon activity and perhaps differential triggering of signal pathways downstream. The Glory 1 study, published in the New England Journal of Medicine, is the first completed phase 3 weight management study of a dual GLP-1 glucagon agonist, and this is with mazdutide. This study enrolled 610 people in China with obesity or overweight with at least one weight-related health issue to receive mazdutide 4 milligrams weekly, 6 milligrams weekly, or placebo to assess the effect on weight. The BMI criteria for obesity being 28 and overweight being 24 in China are lower than in many other countries, so the BMI of participants at baseline here was about 31, which is lower than most contemporary weight management medication trials. At week 48, weight loss was 14% with mazdutide 6 milligrams, 11% with 4 milligrams, and there was a weight gain of 0.3% with placebo. Notably, about 50% and 36% of people achieved at least 15% weight loss with mazdutide 6 milligrams and 4 milligrams respectively versus 2% with placebo. Weight loss had not yet plateaued at the end of the trial, so we need a longer study to know the full capacity of this medication to reduce weight. Metabolic health improved, including blood pressure, cholesterol, fasting glucose, liver fat content, liver enzymes, and physical function scores. Mazdutide is also under study as a treatment for type 2 diabetes. Survodutide is another GLP-1 glucagon dual agonist with the phase 2 data for obesity published in early 2024. Here, 387 people were randomized to various doses, escalated over 20 weeks, maintenance for 26 weeks with lifestyle intervention. Here we see a dose-dependent weight loss ranging from 6.2% with the lowest dose of survodutide of 0.6 milligrams weekly, all the way up to about 15% weight loss with the highest dose of 4.8 milligrams weekly. On the right, for categorical weight loss, we see that a third of patients lost at least 20% weight on the highest dose of survodutide versus none in the placebo group. Importantly, again here, weight is still going down at the end of the trial, so we haven't captured the full capacity of this medication to facilitate weight loss. We'll need to wait for the phase 3 results to see the full effect, which are currently underway. Survodutide is also under study for weight management in type 2 diabetes, in a cardiovascular outcome trial, and also as a treatment for MASH. So now let's look at the triple agonist approach with GLP-1, glucagon, and GIP agonism. So we have appetite reduction afforded by all three, glycemic improvements with GLP-1 and GIP, potential increase in energy expenditure and hepatic lipid metabolism benefits with glucagon, and potential benefits of GIP in adipose tissue. Retatrutide is the only triple G agonist currently in phase 3 evaluation. In the phase 2 study shown here, a variety of initial doses and escalation to various target doses were tested versus placebo for 48 weeks. Here again, we see a dose-dependent weight loss up to 24.2% with the highest tested dose of 12 milligrams. Again here, the weight has not plateaued, so we need longer studies to understand the potential impact on weight. Impressively, 26% in the 12 milligram group achieved at least 30% weight loss. Retatrutide is also under study for type 2 diabetes, osteoarthritis, and obstructive sleep apnea, as well as in a cardiovascular and renal protective outcome trial. Now, we are also well familiar with dual GLP-GIP agonism in the form of tirzepatide, which is already approved for treatment of type 2 diabetes, as well as obesity with or without diabetes in many countries. And we've talked about some of the benefits of GIP agonism already. Now, what do you think would happen if we used an approach including GIP antagonism? Well, a really interesting medication currently under development is maridebart cafraglutide, or Maritide for short. It is a GLP-1 agonist and GIP antagonist. It's not yet clear how both GIP agonism, like in tirzepatide, and antagonism, like in Maritide, could both result in weight loss and health improvement, but based on existing data, this seems to be the case. Another interesting thing about Maritide is that it's engineered in a unique way by conjugating a fully human monoclonal anti-human GIP receptor antibody with two GLP-1 analog agonist peptides using amino acid linkers. And thirdly, it's interesting because the treatment administration is only once a month, whereas existing treatments and others under development we have discussed are generally once weekly. So this 52-week phase 2 study randomized 592 people with obesity into one of 11 different treatment arms with two cohorts, one cohort with diabetes and one without. Various doses and dosing regimens of Maritide were tested, some with gradual dose escalation, some without dose escalation, and with placebo comparisons. Most dose regimens were once a month, with one arm receiving doses every 2 months. Amongst the 465 people in the trial without diabetes, weight loss ranged from 12.3 to 16.2% with Maritide versus 2.5% with placebo. And amongst the 127 people with diabetes, weight loss ranged from 8.4 to 12.3% with Maritide versus 1.7% with placebo. In the diabetes cohort, A1C improved by 1.2 to 1.6% with Maritide versus an increase of 0.1% with placebo. There were improvements in metabolic health parameters with Maritide, such as blood pressure, cholesterol, and hsCRP, which of course is a marker of inflammation. Now, in terms of tolerability of these emerging pharmacotherapies, the theme that we see across all of these medications as common side effects is gastrointestinal, in keeping with what we already know of GLP-1 based medications. Again, these are nausea, vomiting, diarrhea, and constipation, most mild to moderate in severity and transient with dose escalation in most cases. The overarching learnings from these studies and from our knowledge and experience with existing GLP-1 based treatments are that slower titration of medication may allow the best tolerance. It would be ideal if multiple doses of these medications would be studied and ultimately achieve regulatory approval, as it is clear that treatment needs to be individualized with these highly efficacious weight management medications. In fact, in our 2025 Obesity Canada pharmacotherapy guidelines, we advise to titrate obesity medication as needed, as tolerated, and as appropriate to each individual to achieve treatment targets. And coming years will be very exciting times indeed. In addition to the molecules discussed today, there are many other emerging hormone based combination therapies currently in earlier stages of development, including other GLP-1 glucagon dual agonists, GLP-1 amylin dual agonists, or GLP-1 amylin combinations, and others as well. So we'll have to keep a very close eye on this exciting space. So, what does all of this mean for the current and future of clinical practice? Well, first of all, obesity is a chronic disease. It is increasing in prevalence and it is associated with many weight related health conditions. Obesity pharmacotherapies have been shown to benefit for an expanding list of obesity related health conditions. And finally, novel hormone based combination treatments are very promising for highly effective weight management and, importantly, improvement in health parameters. Thank you so much for participating today. It's truly been a pleasure. Please continue on to answer the questions that follow and complete the evaluation.
This program was presented by Medscape Education Global.